Hi, I'm Dr. Kalika. I'm a clinical director at NYDNRehab, and today I want to discuss pelvic floor pain, pelvic floor problem, pelvic pain in general, and to explain and show that what we do is completely different than most pelvic floor PT clinics. I want to discuss the difference and explain how we're different. So, pelvic floor, of course, is a multifactorial problems, and problems can come anywhere from internal pathology, visceral organ pathologies, like postpartum problems, prolapses, different uterine, vaginal, rectal prolapse, constipation, emotional stress, problems with walking, back pain, on and on and on. Pelvic floor is truly multifactorial. And even though there is all these multiple factors, majority of patients with pelvic floor have problems due to problems in their stabilization system and problems with their gait. So problems how they walk. And I think these two are the biggest components that are underappreciated. And in my experience seeing what's done around, I think that most of the clinics addressing pelvic floor from symptomatic perspective. And a lot of the work done by physical therapists in this field are manual approach internally through rectum, through vagina, and I think that even though this has a place, this should not be used so much in the beginning especially. And of course the trigger points and fascial restrictions inside the pelvic floor are painful, and if you manually address them, the pain is going to subside. But the pain is going to come back if you're just addressing the trigger points. And I feel like on a bigger level, those issues that I specifically mentioned, problems with gait, problems with your hip movement, problems with your stabilization system, and how you breathe are really not addressed. And I feel that the immediate go-to vaginal or the rectum trigger point release is really not called for. So what we use here is very different. First of all, we do diagnostic ultrasonography to look inside the pelvic floor and look inside the core and the hip musculature and see what is the problem. How do these muscles contract? How does the pelvic floor contract in relation to the diaphragm, to the abdominal wall, to the interabdominal pressure? How does it change with the hip movement? And all of that is possible through the diagnostic ultrasonography. The second thing that we do that is different, we don't go manually in the beginning at all. Per rectum or vaginally, we use extracorporeal shockwave therapy. We're one of the few machines available in New York, and it's a focus machine. And there's multiple studies that focus shockwave therapy is superior than manual release for pelvic floor trigger points. And the third level, we go for ultrasound guided trigger points. And actually, we've published a number of studies that show its superiority to any other method for trigger points. So unless you have epidental nerve issues, I think that this interdisciplinary and combined approach is really superior to manual trigger point work inside the pelvis. And we also do it at the end, but we remove the bulk of the problem with these technologies. So now that we discussed sort of what we do for trigger points, I also want to talk about the diagnostics. So we have a full motion analysis lab. We do gait analysis for 12 years. We have a 3D gait analysis system. And in my experience, the way people walk is grossly undertaken into consideration for pelvic floor population. I find that the problems with gait is so common and is really not addressed. So the gait analysis technology allows us to look inside how someone walks, and we can fully assess it, and treating the way you walk, treating your hips, treating your feet, really provides a deeper level of symptom relief, because you can keep releasing the trigger points, but if the cause is in the way you walk in, you're really only addressing the symptoms. And the third thing that I want to show you is with ultrasound, we use rehabilitative aspect of diagnostic ultrasonography to retrain the core musculature, the pelvic floor. And I feel like you can have a lot of techniques And this has been my experience. But unless you look inside and see what the pelvic floor does, you really don't know what you're training 100%. So we don't like to take chances. We look inside and we use capabilities of diagnostic ultrasonography to retrain and to see the function and retrain. And now I'm going to demonstrate how. Okay, so this is the ultrasound image, and on top of the ultrasound is kind of complex to understand, but I'm going to try to explain to you what are we seeing here. So right here, this is skin. These are the abdominal muscles. I'm going to demagnify so you can see the muscle tissue, the abdominal muscle, and then you have organs in here, but we need to go to the pelvic floor, and with ultrasound we have an acoustic window through the bladder, and our Sonia has been drinking some water for this demonstration so that we can see the pelvic floor. So this is the bladder, and the bladder is full, so this black is a fluid in the bladder. So what we can see here is the pelvic floor. So if you see, it has this kind of convex, concave and convex shape. So these are your levator ani muscle, and if I slide to the side, what you see here is the connection of the pelvic floor to the hip, to the obturator internus. So if we ask Sonia to pull in her pelvic floor, her vagina, and now let go, you can see that when she lets go, the bladder gets bigger, and this line kind of depresses down here. So we're going to demonstrate it again. Try to pull inside. And right now, this is actually what I wanted to demonstrate, but that people certainly have no idea whether to pull or to push. And this is a very common problem with people with pelvic floor, that they develop excessive pressure through the diaphragm and compress the pelvic floor. Okay, so this is the pelvic floor, and this is exactly the point that I wanted to make, is that without ultrasound guidance, without feedback from ultrasound, it's really hard to know whether the person is pushing or pulling, whether the person is using the pelvic floor or is actually compressing the pelvic floor. So I'm going to show you the demonstration. So if you pay attention to the pelvic floor, the true contraction should lift the pelvic floor up, should lift this up, and the bladder has to pinch and decrease. So try to pull the hammock, your vagina, up, and you can see how this moves up. Relax, and try one more time. Yeah, that's nice, and let go. And you can see that lifted up, but it was pretty weak. It was not strong enough. And we try to get it stronger. That's better. Okay, so what we observe through the ultrasound and how we diagnose and use it as a feedback, we look at the thickness of the pelvic floor. We look at the symmetry of the whole pelvic floor on both sides, right and left. We look at whether the contraction of the pelvic floor is symmetrical as well. And then we turn the probe and we look at how much does the bladder get compressed. We can measure that. And then we slide and go laterally, and we look at the connection of the pelvic floor to the hip. As if we move the hip, what happens to the pelvic floor? So another part of our examination with the ultrasound is looking at the abdominal wall, because the abdominal wall works together with the pelvic floor, the diaphragm and the back muscles, and holding the abdominal pressure mechanism. And examining the abdominal wall on the ultrasound and training it with ultrasound feedback is paramount. So what we see here is abdominal musculature. So this is your rectus abdominis on the right side, and through the fascia it continues, and we see three layers. We see external oblique, we see internal oblique, and we see this very important muscle which is called transversus abdominis. So supposedly, ideally, if you contract the pelvic floor, it should work together with the transversus abdominis, and we're going to see if that happens. Can you try to pull your pelvic floor up again? and relax. So there's a lot of movement in the internal oblique, but nothing happened here. So this is the dysfunction that we commonly see, and we retrain using ultrasound. And looking at what you train is key in pelvic floor. And so if you do it without ultrasound, you're really not sure whether what you're activating is really what you need. And ultrasound provides that advantage of seeing what you do and having the feedback for the patient.